proceed.
I think I'm audible and visible. We'll start off with this session. This is about our NEET SS recall. I'm trying to cover in continuity of what we left in the last session. I understand most of the questions kind of controversial in the sense that we are getting multiple answers as actually the multiple options as answers. So this will be an interactive session for you to actually give inputs as to whether the options are right or is there any changes in the options as well, right? And certain questions might need recapitulating again. So whatever you feel like there is a error in the question or there is a small difference, let me know. We'll get back with the clarifications on the same. So primary mechanism of anabolic steroids in cancer cachexia. Before getting into the question, what is cancer cachexia? What is lost? Is it fat loss, muscle loss, bone loss? What is lost? I think people start interacting. 20 participants are used. Guys, we'll have to finish off as early as possible. Yashmita, Chetu, unmuted. What is lost? Don't put in the chat box. You can unmute and tell. Yeah. So it is muscle loss. Basically, it is disproportionate to the intake. Okay. So this drug is going to be an anabolic steroid trying to address the muscle loss. So it is supposed to increase the muscle mass. Appetite stimulants increasing in the fat or microenvironment modifiers are not related to cancer cachexia. You have microenvironment targeting drugs which might decrease the inflammatory environment. Any example of that? Drugs targeting the inflammatory environment. Drugs like celecoxib, which are used in head and neck cancers, are utilized for targeting the inflammatory, exactly, NSAIDs, environment. They are for disease modification, not for any type of cancer cachexia management. And trying to do the dietary modifications and addressing that will eliminate that component as a factor for weight loss, but it will never have any impact on the actual cancer cachexia, which will need your other forms of treatment. Okay. So it is an agonist of androgen receptor. So androgen receptor agonists are increasing the protein synthesis, thereby increasing the muscle growth and lean body mass. So that is just, which is not a primary cytokine of cancer cachexia.
Leptin, sir.
Leptin. So where is leptin used? What is leptin? What is ghrelin? So leptin is a satiety hormone. Ghrelin is a hunger hormone. G for G for gut. Easy to remember. And gut is obviously supposed to be hunger. None of these hormones are, the contributions will be there, but not as a major factor deciding on this cancer cachexia. It is all an inflammatory cascade which is causing the muscle loss, and this inflammatory cascade, if it is addressed along with muscle loss being addressed through anabolic steroids, will be the funda of treatment of cancer cachexia. Am I clear? So all the inflammatory mediators will be the reason for. So it's a multifactorial post-phagocytic syndrome characterized by continuous decline in the skeletal muscle mass. There can be fat loss, there might not be fat loss also, right? So this is a accepted definition. It can be partially but not entirely reversed by a nutritional support. So these are take-home points of your cancer cachexia. So you have multiple criteria or definitions, weight loss percentages. None of these are actually like standard ones. There are multiple studies on the same, but in general, what they are trying to tell us is the loss of muscle strength because of loss of muscle mass. Cannabinoids, 5-HT inhibitors, NSAIDs, they can reduce tumor-related inflammation and TNF-alpha levels, but not as a gold standard for treatment of. That is why they have given this also in the option. So these are all the options, but anabolic steroids are the gold standard drugs. Along with that, ghrelin receptor agonists are also approved. So you have so many approvals based on different studies. But for us to remember is any anabolic steroid will be the gold standard. Also, how do you assess this muscle mass loss is through CT scans. You have DEXA scan, you have MRIs, you have multiple other modalities to find out the cancer cachexia through body composition assessment. Among that, the accepted one is imaging through either CT scans or an MRI to assess the body composition. Any doubts in this?
No, sir.
Hypogammaglobulinemia.
Yeah, we'll come to this. Any doubts so far? I think no. Huh? So we'll go to the next question. So cancer cachexia, just remember the take-home points: inflammatory stories, muscle loss, anabolic steroids. I think none other question can come even in another exam apart from this. Majestrol acetate, yes. What is the other new drug which is approved for that? Majestrol acetate is used more as a appetite stimulant than as a complete agent for that. What is the other drug which is being used in the trials and has been approved now? Any idea? Olanzapine, exactly. Very good. So olanzapine at a lower doses for a longer term has also gained its importance for weight gain. That way they have found possibly it is helping in cancer cachexia. Whether it is stimulating the appetite or reducing the weight loss, the mechanisms are clearly not known. CLL indication hypogammaglobulinemia. Can hypogammaglobulinemia occur in CLL?
Yes, sir.
Yes. How do you treat that and when do you treat that? So CLL is basically a problem of the B cells that can be for all our practical purposes. When they give CLL, we are taking this B cell CLL. And lymphocyte doubling time, fatigue, weight loss, all your constitutional symptoms and all your obstructive symptoms will be the indications for treatment. Hypogammaglobulinemia, we don't have exact cutoffs. There are reports of this gamma globulin levels below which we can give IVIG. Basically, you try and give IVIG when there is a refractory infection which is not settling with your usual antibiotics and the recurrent. Perfectly right. So all this marrow failures or bulky disease or lymphocyte doubling or your disease related constitutional symptoms. Among this, also remember autoimmune complications poorly responsive to steroids. If autoimmune complications like anemia and thrombocytopenia are happening, your treatment of choice is steroids. And if the patient is responding to steroids, you need not actually treat the CLL. You have to, on the other hand, you will have to prove autoimmune complications as the reason for anemia, because what is your anemia stage in CLL? How do you stage CLL?
So Ribinate staging.
So all your stagings tell us that worsening stages will be associated with anemia and thrombocytopenia. So that is an indication for treatment. But you have to understand whether you are dealing with an anemia of autoimmune pathology or you are dealing with an anemia of the CLL progressive disease. Once you have proven that the patient is autoimmune related anemia and you started steroids and the patient is responding, you need not treat the CLL. Am I clear? Clear, yes? Any yes answers?
Yes, sir.
Yes. Good. Treated for HLL with chemo and mediastinal RT. Now desiring pregnancy after 8 years. They have asked for implications. I hope the options are right. This is what you have provided. If anyone have any difference of opinion in the options, please unmute and tell. Third option is for sure no, because it is not a pelvic radiation. It is gone. None of the drugs, or when do the patients have birth canal, any anomalies? When does chemotherapy cause anomaly?
When given in first trimester.
Basically, during pregnancy, that you are exposing the patient to a chemotherapeutic agent or even a tyrosine kinase inhibitor, the chances of birth, all your teratogenic effects and birth defects are higher, which is not possible after, if you're not giving during pregnancy. So that is also out. Is there abortion chances because of chemo? Will there be chances of abortion because of chemo? Only during pregnancy. Chemotherapy does not have any post effects on the placental implantation or anything else. So now treated for Hodgkin's lymphoma. Think this is a patient of male. Will they have problems with fertility? What is it? You actually
no.
mute and talk instead of typing in the chat box, because that becomes easier and sooner.
Largely, there will be no fertility issues, sir.
That largely equal. How do you define this largely? For which regimen?
ABVD, sir.
Okay. ABVD. So any patient of a practical information for you all. See, if any patient is around 20-25 years, an young male who is just married or yet to be married, who has not started his family, whom you want to start ABVD, we think there is no much of fertility issues. Actual percentage of infertility with ABVD is there anything? Will it never cause infertility or will it at all cause?
So it might cause infertility.
Largely might cause, all are good terms, but
So it will cause.
it will cause to less than 5%. Okay. So do you encourage these patients to get semen cryopreserved? Yes, no.
Yes, sir.
Yes, sir.
Why? Yeah, it is temporary, but do you want to cryopreserve semen prior to starting of ABVD?
So the quality of the sperm is.
Quality of the sperm is good. All are taken.
In 5% cases, if it lands up with infertility, then we'll end up with it.
One is typing that it might be temporary also. Which regimen has highest infertility in Hodgkin's?
MOP regimen,
We are not using MOP at all now. Anyone of us?
BACOP,
BCOP.
Wonderful, BACOP. So when do you use BACOP?
So for bulky disease with unfavorable risk factors,
when after 1 to 2
escalated
cycles,
BACOP or BACOP, when does it come into the treatment protocol?
when Devil's score is a 4 or 5
So when
after
the
first,
patient is not responding to ABVD, you might escalate. So usually we encourage patients to do semen cryopreservation because we might end up in a D score of 3 or 4, and we might have to escalate to BACOP. That is why you do the semen cryopreservation, not exactly only for ABVD. Am I clear?
Yes, sir.
I think possible answer I have covered all. Right. So all the answers are right here. I don't know what is their expectation. What is HLS basically? Exactly, you are right, Afsan. So he might need BACOP. So we advise pump banking for every patient without guessing as to what should be done after D score of 3 or 4. So so what is hemophagocytic lymphohistiocytosis? Guys, unmute and talk soon. Someone to unmute. Right. So HLH or hemophagocytic lymphohistiocytosis is basically all of a sudden there is an extreme immune surge which increases your cytokine surge and causes multiple effects. Who initiates this problem? It can be an infection, it can be an autoimmune disease, it can be a malignancy, it can be familial. Any of these causes might all of a sudden cause an extreme a surge of your T cell activity, your macrophages, and a cytokine surge, causing so many problems. What are all the problems? So you know now the etiology, you know now where is the pathophysiology and what is it going to do? It can cause fever, spleen enlargement, cytopenias. So this increase in the number of T cells and the macrophages in autoimmune disease of the similar kind, it is called as an autoimmune disease goes in for similar kind of picture. What do you call it as?
Macrophage activation syndrome.
Yeah. So is it so when the similar picture is happening because of an autoimmune disease background, it's called macrophage activation syndrome. Through various other reasons, if it is happening, you have this term called HLH. So you have to have the molecular diagnosis consistent with HLH or a either one or two. So if you have a molecular diagnosis, you need not go into the criteria at all. If you do not have, you are supposed to go into the criteria. Why are they asking such bizarre questions? Because in and out, HLH is becoming a topic of discussion nowadays, mainly because you are tending to see so many patients presenting with high grade fever with cytopenias whom we think as leukemia end up in non-leukemic diagnosis, wherein further workup actually gives up HLH-like picture. So leukemia can give HLH. HLH might actually mimic a leukemic picture also. So either way is possible. You need not remember any of these criteria for you to understand this. Just going by this pathophysiology, it actually causes massive engulfment of all the cells in the bone marrow, causing cytopenias, infiltration of spleen, causing splenomegaly, and because of the cytokine rise, there is fever, and as a acute phase reactant, there is triglycerides which are going up. and you can see hemophagocytic evidence in the bone marrow. Here the problem mainly happens because of the NK cell activity being low. So that can also be proven in the laboratories, or a increasing CD25 or a soluble IL-2 receptor, which is again telling you the increasing activity of the T cells. Ferritin and triglycerides are basically acute phase reactants. Acute phase reactants are can be raised in any condition. Herein you see extreme rises, and fibrinogen fall is also a component of this syndrome. Any further explanation needed? Yes, no, at least, please.
No, sir.
Yeah. Acute hyperuricemic nephropathy. What is the normal ratio of uric acid to creatinine? Is it 1, less than 1, or more than 1? So here the answer is very clear. You need not. There is a no, sir. Oh, no for no doubts. Okay. So, and what is the answer here? Less than 1 or more than 1?
So more than one.
No.
Less than 1.
What is the answer?
Answer is greater than 1.
Answer is greater than 1. And what is the normal value?
Less than 1.
Yeah, it is usually in 0.5, 0.8 to 0.6 to 0.8 ranges. Because most of the uric acids are excreted. You are here seeing urinary uric acid to urinary creatinine ratio. So urine creatinine is usually high as opposed to urinary uric acid. Okay. When there's so much lysis that you are seeing so much uric acid in the blood and also in the urine, then the urinary uric acid to creatinine ratio is going to go up. So it is rising both in the blood and also in the urine. So what are the few points about this? It is basically an anuric renal failure. You can see uric acid crystals. You can see or amorphous urates and high uric acid to creatinine ratio. 0.6 to 0.7 being the values for other causes of acute kidney failure. Which is least cardiotoxic?
Say epidubicin.
Right. Any idea about how much dosage of adriamycin is given in breast cancer usually?
60.
So
Less than
60
400.
milligrams per meter
60
square.
milligrams per meter square, along with cyclophosphamide of 600 milligrams per meter square. If you are using epirubicin cyclophosphamide, what is the dosage?
90 milligram per meter square.
90 milligram per meter square. So that is very, very safe. So you had doubts about this doxorubicin dosage maximum recommended dose. And we were discussing that a lot, but herein they have asked a different question, but still known one. 550 is the number which you are going to take up for doxorubicin. Daunorubicin has different values based on the chest irradiation and so on. Epirubicin is 900 milligrams per meter square. Individual drug values will not be asked. It will be, answer is epirubicin.
So it is about cumulative dose.
Cumulative dose per meter square.
Okay.
Right? So if you give 4 cycles of adriamycin at 60 milligram per meter square, 6 4 24, you are going only 240 milligrams per meter square. Worst case scenario, you might use 6 cycles in FAC regimens, wherein you might end up giving 300 milligrams per meter square or 360. Even then, it will not cross 550. Okay. Epirubicin is that is why answer for the HLH question, I don't know if the options you gave all are right. Hypertriglyceridemia is there, elevated soluble. It is hypofibrinogenemia. So answer will be hyper.
Yes, sir.
So fibrinogen is the only thing which is supposed to be decreasing. Apart from that, all are going to increase. And the other one is the NK cell activity, which is going to drop. Okay. Clear. So this is one other regimen called flag idea. I basically put you into this because idarubicin, if you see, it's not it's given here 150. It is very lower dosage. Mitoxantrone and idarubicins are cardiotoxic at very smaller doses. Okay. Febrile neutropenia. What is the most common organism?
E. coli. Gram negative.
Yeah, so you have 2 gram negatives here.
Pseudomonas.
Pseudomonas is some people, some are saying E. coli. So you are fairly ruling out enterococcus and strep pneumoniae, if I am right. Okay for that?
Yes, sir.
Yes. Now you have an option of Pseudomonas or E. coli. See, there are so many trials. Each and every my hospital has having a different antibiotic policy and a different spectrum of all your bacteria. Others will have different. But the funda to so how do you actually think is the answer to be right in this question based on your treatment? So you are supposed to give an anti-pseudomonal agent as your empirical therapy for febrile neutropenia. Am I clear? So that is why most common organism will be very vague to remember. So far, the traditional teaching has always been Pseudomonas, and henceforth, the empirical antibiotic of whatever you are going to choose is supposed to have a pseudomonal cover. In trying to imply that Pseudomonas is the most common organism. If you are taking this question, that is the most common organism, right? It might vary between the institutions. See, this guy says every other possible bacteria. This says Pseudomonas at a little higher percentages. So each one will have different spectrums. Each hospital and institution will have different. The organisms might differ based on their antibiogram and their hospital environment. But to answer this question, and the reference for this is taken from the concept that any febrile neutropenia because of chemotherapy is treated even before you get the culture reports with empirical antibiotic therapy, which should cover Pseudomonas. Am I clear?
Yes, sir.
Right. So not associated with paclitaxel cardiotoxicity. What is not? What is the most common cardiotoxicity of paclitaxel?
Sinus bradycardia.
Sinus bradycardia. So if that was the question, answer is easy. Now what is the answer?
So
Non-ischemic
ventricular fibrillation.
cardiomyopathy.
Yeah, I too had to search for this. And what I have found is this. Sinus bradycardia is most common, observed in around 30%. Cardiac dysfunctions can be of these 3 types. Initially they had the fear of arrhythmia. That is why when paclitaxel came into the protocols, patients were given paclitaxel in the intensive care setting under cardiac monitoring. Now that you are giving left, right, even in your normal wards, but that is was the practice initially, mainly because of arrhythmias, but all are usually reversible arrhythmias. Ventricular repolarization abnormalities might happen. Ventricular fibrillation is, so all the arrhythmias are possible. So asymptomatic bradycardia is possible. Ventricular fibrillation is possible. Pericardial reactions are possible. Acute coronary syndrome is possible. So it can be a non-ischemic cardiomyopathy also. Why so? There is a component of chronic cardiac dysfunction also. It is not only acute. Acute is usually within 4 weeks. After 4 weeks is chronic. Chronic can again be an early cardiotoxicity or a irreversible more than a year is irreversible cardiotoxicity, which can have a diastolic or a systolic dysfunction, irreversible cardiac failure. So all these are possible. QT prolongation followed by bradycardia followed by atrial fibrillations, all these are possible. So, and this is one of the studies which I could collect, which says, you can read the last line. The results do imply that paclitaxel alters sympathetic control of blood pressure. Nevertheless, paclitaxel does not appear to precipitate autonomic cardiac neuropathy. So hypertension is possibly the, if hypersensitivity is also given, I don't know how can hypersensitivity be a cardiotoxicity. If hypertension was the option, possibly that is the one which is not associated with paclitaxel cardiotoxicity. Any doubts? Any doubts?
No, sir.
Right. So what is the answer here?
Hypertension.
That's okay. Next one, 26.
So doxorubicin.
Why is it so
Sir.
doxorubicin?
Adria cells.
Adria cells. What are the two peculiar adria cells?
So
What is
vascular
vascular
degeneration.
Vascular degeneration,
myofibrillar
myofibrillar loss.
The biopsy showing myofibrillar loss is an extreme story because usually myofibrillar loss is diagnosed through what microscopy?
Electron.
Electron microscopy. Vascular degenerations are seen in histopathological examinations. Okay. Trigger point injection. I too had to just remember.
So
See?
focal
Focal muscle pain.
Okay. So inflamed muscles triggers are given in trigger point injections. Highest transformation of malignancy with was there gastrinoma in this?
Yes, sir.
Yes, sir.
Yes, sir.
In this, in among the options, gastrinoma was there.
Yes,
sir.
sir.
That has the highest potential. Okay. If you are taking functional, see, what are these called? Insulinoma, glucagonoma, gastrinoma, EIPoma. All these are called functional neuroendocrine tumors of pancreas. Those without any function will be called non-functioning neuroendocrine tumors of pancreas. Among the functional, which is the least one to get into malignancy?
Insulinoma.
Insulinoma. Because that is the most easy answer, they did not ask. And they wanted to ask which is the most common, which is the most malignant transformating potential is gastrinoma. Okay. Any doubts?
No,
Any
sir.
or no? All right. I'm not checking the chat. So 1 second. Hypertension was not there. Then what was the other option? Paclitaxel question.
Possibly only hypersensitivity was there, sir.
How will hypersensitivity? Hypersensitivity is not a cardiac toxicity at all.
Yeah, but they mentioned it.
But sir, they mentioned hypersensitivity
They
reaction.
mentioned hypersensitivity.
Nonsense question,
Did,
sir.
did a human make a question or the question was also made by AI?
Question was also made by
Good question.
So the next doubt is whether the correction will be by a human or that will also be done by an AI.
The
So,
AI will give the key. You just have to follow that.
so going forward, DocTutorials will be taken over by AI. That is what is going to happen. All probably. And the worst case scenario is medical oncology taken over by AI and patients seeing AI for treatment options.
So we had that question.
That will not happen.
Oh,
So that question was already asked.
oh my God. So that is a question. So
Yes,
what's
sir.
going to happen has become a question now.
Replace the medical oncologist. AI will replace the medical oncologist. That was one of the options.
So as of now, that will not be your option. As and when the AI takes over, you will not be in a position to even answer.
Yes, sir.
Right. What is this question about? Where fentanyl patch is least effective? Cachexia
Cachexia.
initiation leads to immediate.
Initiation leads to immediate response.
What is this?
So usually fentanyl necessitates continuing other drugs for some period of time.
No. What the question says, where fentanyl patch is least effective.
In cachexic patients, the absorption will not be proper.
Yeah, that is right. But fourth option is totally irrelevant to the question.
Sir, the question might have been which is true about fentanyl patch or which
Yes.
is not true
Yes,
about
sir.
something like that.
Which is not true.
Right.
Yeah, the question was which of the following is true about fentanyl patch?
Right. So fentanyl patch, opioid or non-opioid?
Opioid, sir.
Opioid.
Opioid, sir.
Opioid. How long can you keep a fentanyl patch? Whatever may be the mg.
3 days.
72 hours.
72 hours. Okay. So what is the less opioid? I mean the drug which is given at a longer duration for a least opioid effect.
So buprenorphine.
Buprenorphine. Perfect. So this is for you people to decide as to what will be the question and the answer. Right. Ipilimumab causing diarrhea. What is the most common side effects of? You can have multiple IRAEs, no? Immune-related adverse events. Among the immune-related adverse events, which is the most what is ipilimumab?
CTLA4. Yeah,
CTLA4. Name another CTLA4 inhibitor.
Tremelimumab.
Tremelimumab.
Very good. How many doses of CTLA4s are given in any protocol?
Primarily was single dose, sir.
Even ipilimumab was given only for 4 cycles. So what is this called? Why are you doing only some doses? Why don't you-
CTLA4 priming.
Yeah, so it's called CTLA4 priming. You need not actually continue CTLA4 inhibitions on a longer term. Why so?
Because it has more adverse effects. CTLA4 in.
Yes, accepted. If the patient doesn't have an adverse effect, well and good, you can continue. So it is only required for priming your CTLA4 for immune activation. Okay. Otherwise, what you are going to do is a PD1, PDL1 blockade for the responses. Now coming back to the question. What are all the most common? I mean, it is tough to say which is the most common one, because every other immunotherapeutic agent might have differences in their autoimmune pathologies. Among all these, diarrhea or colitis is very common with ipilimumab. For that matter, any CTLA4s. If that happens, how early is it supposed to happen, or does it happen in a later stage? So any colitis of this ipilimumab happens little early during the initial courses only. What do you do for grade 3, grade 4 events? Forget ipilimumab, forget immunotherapy.
So we stop the
Stop
drug.
the drug. Stop
We
the drug.
stop the drug. Wonderful. Do you so stop the drug, treat the condition? What will be the next question to answer there?
So
Can
shift
you
to another drug.
re-challenge? Can you re-challenge with this?
Can you re-challenge? So these 3 questions only to be answered for any grade 3, grade 4 event. Okay. So if you read also in future, so you need not worry how will I remember each drug's grade 3, grade 4. So they are not intending to ask in that manner. They want to know whether you know for grade 3, grade 4, no point in continuing the drug. So reducing the dose is for which grade and which drug?
Grade 2.
Of which drug? Ipilimumab or pembrolizumab?
So pembrolizumab.
None of the immunotherapies are supposed to have a reduced dose.
Yes.
Low dose immunotherapy concept is different. But when you have an immune related adverse event, it is not dose dependent. So no point in reducing the dosage. So that option itself is wrong. Clear? Understandable?
Yes.
Yes,
Okay,
sir.
sir.
Yeah. Restarting immunotherapy once resolved,
No, sir.
keep it aside. Discontinue and put on steroids for 4 to 8 weeks. Discontinue and taper over 7 days to preserve immune drug function. I don't know what is that. So any grade 3, grade 4 event, from grade 2 event onwards, start your workup and don't get fixed that any diarrhea is for a patient who is on immunotherapy, any of the symptoms, be it cough or diarrhea or any skin reactions, just approach it in a broader way. Don't get stuck to one point that it is all immune related. That is why I put this column. So you have to do all the extensive workup to rule out the other causes also. Clear?
It's a diagnosis of exclusion. Like you have to exclude all other causes and
Yeah.
then.
But still, someone is with grade 3, grade 4 diarrhea will not be waiting to start steroids. I'll be doing that and working up in the parallel manner also. Clear? So it is not one diagnosis or one point of your workup. You are supposed to think in a broader manner. This is what you are supposed to do when you are going into the medical oncology. Grade 1, grade 2. How many stools per day is grade 1? How many stools per day is grade 2? Is not your problem again. None of the questions are going to ask in that manner. So don't put your brains into that and get confused again. Only grade 1, you are going to continue the immune checkpoint inhibitors. From grade 2 onwards, you are going to hold the immune checkpoint inhibitor until recovery to grade 1. Okay. Grade 3, grade 4 onwards, you are going to see grade 2, again administering corticosteroids, tapering over 4 to 6 weeks. Okay. Grade 2, grade 3 onwards, you are going to put them again on corticosteroids at a little higher doses for around 6 weeks of duration. You might require other agents like infliximab or vedolizumab. All the other steroid sparing agents might be required. Grade 3 onwards, remember you are supposed to admit the patient. These are general points for us to remember. Should consider permanently discontinuing CTLA-4 agents from grade 3 onwards. Clear? Any other point to be discussed? So grade
What
3.
do they mean by preserve immunodrug function?
Which one?
The second option they
Second
gave, taper over 7 days to preserve immunodrug function.
If this is the real option, I don't understand the option also. They probably wanted to taper the steroids over 7 days or what, whatever it is. See, even for grade 2, if you are starting steroids, you are supposedly taper over a longer term. Tapering early to preserve the function of the drug has no meaning. Clear?
So once it's grade 3, grade 4, we do not re-challenge with the same drug.
Yes. For CTLA-4.
Okay.
Number again. Right? Clear. Which grade 3, grade 4 event you are not worried about rechallenging?
Skin toxicity, like skin rashes.
They're going for toxic epidermal necrolysis. Will you restart? You won't.
Yeah.
Which side effect you can manage only with replacements?
Endocrine.
Hypothyroidism.
Cytopenia.
Endocrinopathy.
Endocrinopathies. Wonderful. So endocrinopathies, you are going to give the supplements and continue the drug. Clear? These are the take-home points of IREs. Symptomatic ex-officio. What next?
So biopsy.
1 second. Just a second. Sorry for an amount. Sorry for the interruption. Symptomatic SVC. I don't understand what do they want to get from this.
What is the next
Sir,
step?
question
Yeah.
was patient was having progressive dyspnea but hemodynamically stable. So what should we do?
So what is the answer?
Biopsy.
It was
Biopsy.
CT guide biopsy.
To biopsy, treatment, everything at a single go. So it is not like, it's not a sequence here. One local biopsy, put this patient on tumor lysis, some prophylaxis, start the patient on steroids, get an FNAC done along with the biopsy, check the FNAC on spot, whether it is carcinoma or a lymphoma. If at all it's a carcinoma, try and do chemotherapy or radiation. So see, this is what is from Devita. Chemotherapy for SCLC and NHL. NSCLC best treated with radiation therapy. These are very discrete answers, but it is not always right. Okay.
So the option was core cut biopsy.
Yeah. True cut biopsy is the next step. So without establishing, so your aim is to establish a diagnosis and waiting for the emergency treatment. Okay. So your first aim is to establish the diagnosis. So FNAC biopsy. So even when you are starting to practice, don't do a biopsy and finish it off. Get a FNA also done if possible, because it's just a bedside diagnosis. You will know whether there is a carcinomatous component, lymphomatous component, and what you are dealing. Most often you will get to know from an elderly male smoker. Most probably it is an SALC or an NSCLC. Some young patients or a non-smoker where you suspect lymphoma or carcinoma, then you have a difficulty. Right. This aside, what is the most, what cancer will, what are the cancers which can cause SV syndrome?
Small cell lung cancer.
Right. What is the most common cause if you put malignancy and non-malignancy together?
Malignant cause.
Malignancy. Among malignancy, which is more common?
Lung cancer.
NSCLC.
Lung cancer. Don't get confused with this percentages. NSCLC is very means more common than SCLC. So, but SCLC presents more with mediastinal. So, what to choose? Just forget. They will not get into all these controversies. NSCLC 80 to 85%, SCLC 15% is the prevalence. Mediastinal more often in a small cell than non-small cell. Why is it so? Why small cell is more common in mediastinum?
Central location.
Why central location is more common in SCLC? You think no. Peripheral NSCLC. Central
NSCLC.
small cell. Why? Why so? Anyone to answer this? Someone wants to answer? So basically, which type of
Kulchitsky cells are found in the bronchial lining.
No. Which tobacco is more commonly a causative agent of small cell lung cancer? Which form of tobacco?
Smoking.
Which smoking?
Secondary smoke.
BD smoking or cigarette smoking?
So BD.
Why?
No filter.
More larger particles, no filter, settles in your larger airways, gives a mediastinal problems. Filter cigarettes, smaller particles, has a filter, goes to the peripheral airways and gives peripheral non-small cell lung cancer. Clear?
Yes.
Yeah. So another question to the same. So you know lung cancer is more common. Other than that, any other cancers? Other than that, any other cancers?
Primary mediastinal
Thymoma
lymphoma.
So
and jaundice.
Lymphoma.
lymphoma, thymoma, anything else?
Germ cell tumor mediastinal.
Mediastinal germ cell tumors.
germ cell tumors. So mediastinal tumors like thymoma, germ cell tumor. Even metastatic cancers can cause mediastinal widening and SV syndrome.
So breast cancer, metastatic breast.
Metastatic breast cancer. Don't forget. Cyanotic and diarrhea post 2 days of administration. What is that?
Loperamide.
The loperamide
When do you give atropine?
Within 24
within
hours.
24 hours.
Okay. Why atropine?
It's anticholinergic.
Why cholinergic diarrhea?
So that I don't know.
Right. So acute onset only atropine is used. For non-acute diarrheas, you are supposed to give loperamide. So this is how you are going to see chemo-induced diarrhea. Irinotecan, yes, atropine. This is in the initial setting. Otherwise, standard dose loperamide. And reassess after 12 hours or 1 day. If it is ipilimumab induced, then you are supposed to give steroids. If not, you can switch to high dose loperamide or dioxyphenolate, diphenoxylate, atropine combinations. What is that drug called? If still not resolved, add other agents also. This is in short about chemotherapy induced diarrhea. So now among this, what is the least likely cause?
Thymic carcinoma.
Thymic
Carcinoma.
Carcinoma.
So just to read each line, I think I have collected all this from data only. Malignant disease is the most common. Small cell and squamous cell are the most common histological subtypes. Lymphoma is the next common. Among lymphoma, it is DLBCL and lymphoblastic lymphoma. Primary mediastinal malignancies of thymomas and germ cell tumors can happen. So in general, non-Hodgkin's lymphoma, small cell lung cancer, and germ cell tumors constitute almost 50%. Hodgkin's can involve but rarely causes SV syndrome. Breast cancer is the most common metastatic disease to cause SV syndrome. And rarer tumors like thymic malignancies very rarely. Clear? Hypercalcemia of lymphoma. What is the reason?
It's a parathyroid.
Vitamin D.
125 dihydroxy.
So was it a parathyroid hormone or parathyroid hormone related peptide?
It's a parathyroid.
Parathyroid hormone.
So what are the 4 mechanisms?
Humoral hypercalcemia of malignancy.
Lytic.
Fresh from MCQ preparation. So lytic, humoral, vitamin D, ectopic hyperparathyroidism, all 4. Among this, most common is humoral. Okay. So if they have not given humoral, then among the options, it is vitamin D. Okay. Any doubt?
No,
So
sir.
humoral was on the options, I think.
Then that is the most common.
The humoral was not in
But
the.
it was lymphoma, no?
Yeah. Vitamin D related is usually from a lymphomatous tissue. Okay. Which is not true regarding testicular tumor. What are the anti-tumor antibiotics?
The
Bleomycin.
Bleomycin, mitomycin.
doxorubicin.
Right. Very good. So what is the answer among this?
What is the
Choriocarcinoma.
prevalence?
So what is the prevalence?
Less than
0.3%.
1%.
Less than
Yes, sir.
1%. These are the anti-cancer antibiotics. All your anthracyclines and then your bleomycin. Mitomycin also. These are, and actinomycin D. Remember mitomycin, bleomycin, and actinomycin D. All your sins. Okay.
Sir, answers to question number 32 and 33. 1 second, sir.
1 second. This is thymic carcinoma.
So why not breast cancer, sir? Because in the cause of thymic carcinoma is also there, sir.
Thymic carcinoma is very rare among thymus tumors. Okay. Thymomas can VM primary, very commonly happening in primary mediastinum. Rarer, that is why I put you the last option. Rarer tumors such as thymic malignancy, pleural mesotheliomas, sarcomas, and primary mediastinal tumors can cause. Thymic cars, that is why they were also very clear to give thymic carcinoma than as thymoma. Okay.
Yes, sir.
This is on this. If these are the options, vitamin D is the answer. Ectopic hyperparathyroidism is extremely rarer entity. Okay. Among in this, it is choriocarcinoma. So what is this? Coronoscore. What are the coronospores?
Thromboembolic events in cancer patients.
Yeah. So you may not remember the scoring. Remember very high risk cancers which can cause this. These were INA SS questions. I don't know how that got into the NEET also. So stomach and pancreas are the cancers which have highest risk of thromboembolism, followed by other cancers. Platelet count, hemoglobin, lymphocyte count. So BMI, one complete blood count, and what cancer. These three are the parameters used. So body mass index, complete blood count to show your hemoglobin, platelet, and WBC, and what type of cancer. These three parameters are taken into coronoscopy. Which score and above which is problematic? More than or equal to 2 is problematic. You see the right end here. Is my arrow visible? So intermediate or high risk VTE, coronoscore more than or equal to 2. Consider anticoagulant prophylaxis for up to 6 months or longer. Okay, so the option is wrong if they give 3 months. Aspirin, obviously not. You're not going to wait. So what is the answer?
So D.
So low molecular weight heparin and compression stocking.
Exactly. So that has not given the option of duration. So any cancer related thromboembolic treatments supposed to happen for at least 6 months. Okay.
So if this was not a cancer patient, then aspirin and observe would be sufficient. Right?
Non-cancer patients, I am not aware.
Okay.
Also remember contraindications to prophylaxis. Any active bleeding, thrombocytopenia. Why this? Less than 50,000 only are not going to give anticoagulation. 75,000, don't say platelet is low and you are not going to give anticoagulation. So contraindication is only less than 50,000. That is why I put up this. Okay. Best fertility method. What is it?
So oocyte cryopreservation.
Why not ovarian tissue?
So it's difficult to perform.
Oocyte is also difficult. Nothing is easier here in life.
Yes, sir.
I think I have not put up that slide. So, ovarian tissue cryopreservation, they have not given the cancer per se as which cancer. No. Ovarian tissue cryopreservations have been reported to have cancer development in the cells which are preserved. So, oocyte is the answer. So, any female patient evaluate for gonadal toxicity. If they want to preserve fertility, you have at least more than 2 weeks available for starting the treatment. Then you do oocyte cryopreservation. You don't even have 2 weeks, then you are supposed to do ovarian tissue cryopreservation. Am I right? Am I clear?
Yes.
Whatever you do, you are supposed to have GnRH analog. Okay. Just because you have preserved oocyte or ovarian tissue, you cannot omit GnRH analog. And only doing GnRH analog is not a good option. Yeah. So for males, sperm cryopreservation. For females, they want to preserve fertility, availability of more than 2 weeks, oocyte cryopreservation. less than 2 weeks, ovarian cryopreservation, ovarian tissue, and almost always GnRH agonist. Highest risk of infertility, what?
So cyclophosphamide.
Cyclophosphamide.
Why?
So it is the most immunosuppressive drug ever.
Ever in the life, someone discovered a worst drug. So all your alkylating agents have highest risk of chronal toxicity, more than 80%. Okay. Followed by cytarabine as the next more cytarabine, mentristin. Others you need not remember, just remember the highest with all your alkylating agents. If not for cyclophosphamide, any of the alkylating agent, if it is given, you have to choose that. It can be ifos, carmazine, busulfan, lorambusil, melphalan. After transplant, you don't see any patient going into fertility. So now coming back to our febrile neutropenia, what is? So answer D is right or wrong?
Wrong.
Wrong. When do you give vancomycin also?
Gram positive.
Gram positive. I understood. That is gram positive cover. When do you want to cover for gram positive?
So empirical.
Empirical.
So I don't know.
Catheter related
Very good.
infections.
Patient with catheter in situ, even if there is no catheter related infection, if the patient has a fluoroquinolone prophylaxis already, patient has a severe mucositis, patient is having a shock, the patient is having a pneumonia, if the patient is having a skin and soft tissue infection. These are indications for you to start a gram positive cover. Right. Among the other options, ceftriaxone, yes or no?
No, sir.
Why?
So we don't give single agent.
You can use single agent.
It's a very weak drug compared to other options.
Very weak. How weak it is? What is the funda for us?
So both gram negative and gram positive.
Covering both gram negative, positive.
What is
and
the
other-
one which is supposed to be? What was the most common organism?
So pseudomonas.
So how is the cover supposed to be?
So more gram negative strong.
So
Anti-pseudomonal.
Anti-pseudomonas.
clear? So you want a drug which has an activity against pseudomonas, like cefoperazone sulbactam, ceftazidime avibactam, cefepime, meropenem, or piperacillin tazobactam, and so on. So now the choice is between meropenem or piperacillin. Was it piperacillin gentamicin?
Yes, sir.
I'm stuck again. I don't know. So I'll get you through. See, this is what is in Harrison. Commonly used antibiotic regimens for treatment of febrile patients with prolonged neutropenia is ceftazidime or cefepime, piperacillin tazobactam, or imipenem or meropenem. Again, piperacillin tazobactam, actually that would be the answer than meropenem, because carbapenems are less attractive as an initial regimen. Okay, usually reserved only for ESBLs. Clear? So what is the answer?
So in up to date, it's written that if patient is having sepsis and hypotension and all, that time we can think of adding aminoglycosides. Otherwise, we can start with meropenem or ceftazidime or only piptas.
So any hospital policy is to give a doublet agent. Okay, we are following cefoperazone sulbactam with amikacin. In that sense, for me, piperacillin and gentamicin is a good combination. Okay. Meropenem alone will not be an attractive one for a patient who is not having already a inherent sepsis and shock and all those things. So to me, answer is piperacillin, gentamicin. What group
You
is
piperacillin tazobactam, not gentamicin.
piperacillin tazobactam with gentamicin.
Okay.
Tazobactam is only a beta lactamase inhibitor, no?
Okay.
So Piperacillin is piperacillin tazobactam. That is taken for granted. Clear?
Okay.
Yes, sir.
So what is gentamicin group?
Aminoglycosides.
Aminoglycoside. Aminoglycoside is protein synthesis inhibitor or cell wall inhibitor.
It's a protein synthesis inhibitor.
Is it so?
So not sure.
So this is the only combination where you give two cell wall inhibitors, like your penicillin and aminoglycoside. Both are cell wall inhibitors. Okay.
Okay, sir.
So these are general dictums. No point in remembering all this. So appearance of erythema on the exit site, positive culture for MRSA or coagulation negative stuff. All these are indications for vancomycin, apart from whatever I told you. Whatever I told you, skin soft tissue, pneumonia, sepsis shock, catheter, prophylaxis with fluoroquinolones already, severe mucositis, all these are. Okay. Medullary carcinoma thyroid, which is not an indication.
High
High
calcitonin.
calcitonin.
Residual disease. High calcitonin is what, basically? If calcitonin is high, imaging is positive for symptomatic disease, you call it as recurrent. If imaging is negative, you are supposed to just repeat your calcitonin levels. So even if your calcitonin is high and imaging is negative, or the patient is not having symptomatic disease, I mean imaging negative or asymptomatic, you are just going to repeat your calcitonin levels. Am I clear?
Yes, sir.
CDK4/6 inhibitor.
G12S.
Who says?
Right. Mitogenic signaling, cyclin D, cyclin CDK4/6, phosphorylation, dissociation, E2F will go on, start your transcription program. If you have a CDK4/6 inhibitor, it will stop your G1S transition. Okay.
So I have a doubt. The half-life of calcitonin is very high.
Hmm.
Is very short. So why is it high, like even after resection? Like where the levels are raised even after resection?
Exactly. See, does high calcitonin and imaging negative, what does that imply to us?
It's a
It
residual.
could be ectopic.
Imaging is not sensitive.
That is all. High CEA can have again a negative report. Okay. You can have a high CA 125, still imaging negative. Doesn't mean that you will have other causes also, but that doesn't mean that there is no disease and where did this calcitonin come from and why is it high still. There can be an imaging undetected disease still, but still you're not treating because there is no survival advantage of treating an imaging negative disease. Clear?
Okay.
So extra thyroid extension can be metastatic also.
Why will it be metastatic? Extrathyroidal extension is not extension to somewhere else. It is just an infiltration of the surrounding areas.
Okay, sir.
Like locally advanced kind.
Like a locally advanced, inoperable kind of picture. That is why all your tumor markers are not taken into account in isolation for you to start treatment. What will be the bias there? It's called lead time bias. You are trying to treat, you are actually treating the disease. You might treat and bring down the levels, but it is not actually giving a survival difference. Then no point in treating. Okay.
Okay.
If you are deducting and treating something, even some recurrences, you can actually observe many prostate cancers. You have active wait and watch policy. Why? That disease is not going to. So no point in treating and giving some toxicity to that patients. Clear? So where do you use CDK4/6 inhibitors?
Metastatic breast cancer.
Breast cancer of
Hormone
which
positive.
type?
Hormone
So,
positive.
hormone positive.
2 should be negative or 1+,
Negative.
whatever it is. Why not in triple negative? it is a good drug which is inhibiting GDK4/6, which is in the cell cycle. No, it's a cell cycle inhibitor. Does it differentiate between ER positive or ER negative? HER2 is different story because therein you have a HER2 targets. Your thought is going towards targeting HER2. Here, whatever it is, if the cell surface has ER or whatever it is, what is it to do with the cell cycle?
So all the studies have been done in ER positive patients
Why
only.
did they do the study in the ER positive alone? Why didn't they do in this? Like I start in TNBC, is it good? And I come up with a positive answer. Why didn't they come up? So where is this CDK4/6 acting?
Through RB retinoblastoma.
So go back, read what is the RB gene problems in triple negative. Okay. RB genes have peculiar stuff in triple negative patients. That is why this drug is not active there. Clear? Always go back when you are getting into medical oncology. So many contents will be put into your brain saying it is trial based, but none of them are without any concept. So try to read the concept. You will get to know why the thought process came at all. Okay.
So that HER2 doesn't work through this RB pathway. Like HER2 overexpression, when there is overexpression, it doesn't act through this RB pathway.
I didn't get you. Triple negative and retinoblastoma. In the next session, I will ask you a question. Just read what is retinoblastoma gene and triple negative cancers. What is the correlation and what, because of which CDK4/6 inhibitors are not given in triple negative.
Loss of RB in TNBC.
You are almost near to the answer. Good. And why that also you'll have to find. Okay.
Okay.
What is this not true about cancer pain? What do they want?
Other options we don't remember.
Right. So cancer pain, what is that ladder?
WHO ladder.
This ladder you will have to remember. Easy, but remember, fourth ladder is your interventional treatment. I don't think anything apart from this is supposed to be asked. Okay. Anything else to discuss in this part? So which is the most malignant potential among this?
Hepatic
Hepatic
adenoma.
adenoma.
Very good. Hemangioma, you don't know. Focal nodular hyperplasia is a DD4. Okay, not into the details. So malignant transformation is horrible with hepatic adenomas only to an extent of 8 to 10%. Okay, what is this? What is the problem in this patient? Forget the answer.
Chronic GVHD.
Chronic GVHD. So chronic GVHD basically happens here, wherein there are three problems: thymic dysfunction, B cell activation introducing antibodies, and deficiency of Tregs, that is T regulatory cells. So basically it ends up in an autoimmune type of picture. So all autoimmune problems will happen in a chronic GVHD. So remember very simply. In simple terms, anything which mimics an autoimmune pathology will be the similar pathology for chronic GVHD also, as opposed to acute, which is a totally different story. Okay.
But can't it be late toxicity due to radiation?
What radiation would an AML patient have received?
So TBI.
And TBI effect. Why will TBI be in? Usually AML protocols will not have TBI. TBI is used in which protocols? And why?
Conditioning regimens.
Of which cancer? Usually in ALL.
Yes.
Why? Because in ALL there are so many sanctuary sites like your CNS. And
Yes, please.
so In ALL only, we try and utilize, not that you should not use TBI in AML. Most of the time, we end up using other regimens of conditionings in AML than TBI based conditionings. Okay. Clear?
Yes.
Yes, sir.
L-asparagine is the answer.
Pancreatitis.
L-asparagine mechanism. I'll tell you why I'm asking the mechanism. Mechanism of L-asparagine. See, L-asparagine is basically going to do this one.
Depletes asparagine.
Some cancers are deficient in asparagine synthetase enzyme, and they cannot manufacture sufficient quantities of this essential amino acid to maintain cell viability. In these patients like leukemia, like ALL, we are giving L-asparagine, which will catalyze the hydrolysis of L-asparagine to L-aspartate and ammonia. Basically, asparagine is broken. Asparagine is an essential amino acid needed for the cell. It is broken by this L-asparagine. That is the mechanism for anti-cancer activity. But the mechanism behind this pancreatitis and other thrombotic neurologic complications is glutaminase activity, which is also possible, which is also a component of your anti-tumor activity. Am I clear?
Okay, sir.
So there are two things with L-asparagine. One is L-asparagine destroying asparagine, and the other one is L-asparagine depleting glutamine. Both these have anti-tumor activity, but only glutaminase has all these side effect profiles. If pancreatitis happens, what do you do for the drug? Do you re-challenge? Yes, no?
No.
And go back and read what are the types of L-asparagine, E. coli, this, that. Mostly will not be a question. So, what is this question trying to ask you?
It's a
Platinum sensitive or platinum relapse.
What is the answer? Platinum refractory or
Platinum chemo.
Platinum
It is still
chemo.
platinum
Platinum
sensitive.
sensitive.
More than 6 months.
What is platinum sensitive?
Relapses after more than 6
More than 6 months or 1 year?
6 months.
6 months.
Then what is more than 1 year called? That is also sensitive. This is also sensitive. Less than 6 months is called?
So refractory.
Then what is resistant?
So while on the chemo, if she develops recurrence.
So more than 1 year is platinum sensitive. 6 months to 1 year is partial platinum sensitive. Less than 6 months to more than 3 months is platinum resistant. Less than 3 months is platinum refractory. Okay. So all are number defined. So this is what?
Partially sensitive.
So the word is that platinum sensitive. Patient is asymptomatic. Do you treat or not?
So we will treat because there is recurrence in imaging.
Yes. So even if the patient is asymptomatic, you cannot stop or wait for treatment. Now what treatment? So option D is out. Among these three, what do you want?
The platinum chemo.
Platinum.
Why not olaparib? BRCA mutation.
So olaparib is given with chemotherapy and it is used as maintenance agent.
Why not a single agent? Solo 3 was supposedly a similar trial. When do you give single agent?
So on maintenance therapy.
Patient is not wanting chemo. Do you give? So basically, you are right. Maintenance only, even in the first line, second line, whatever line you are doing, olaparib is only for the maintenance setting. It is not used as a single agent. It was approved as a single agent, after which the FDA has taken back the approval. You can give single agent only if the patient is not fit for chemotherapy. Clear? Am I clear?
Yes, sir.
Yes, sir.
What is the treatment?
Stimulant laxative.
As a stimulant laxative.
Oral naloxone.
I'll just means so big. Do not get into the intricate detail. Just remember, see, most common regimen is all this senna, blah blah, all this stimulants like senna. But the last paragraph, if you see, the third paragraph, methyl naltrexone is first available peripherally acting opioid antagonist. Why peripherally acting? It will not have an opioid withdrawal syndrome. Okay. Naloxone is totally not the answer. Fourth option is available, but treatment is stimulants. Okay.
Yes, sir.
Beta-D-glucan or galactomannan. What are the differences?
So, don't know.
See, most fungi, excluding mucor and cryptococci, will secrete beta-D-glucan. Galactomannan is mostly for aspergillosis. So, routine use for Candida and aspergillosis beta-D-glucan. Only aspergillosis galactomannan. Okay. You have next thing to remember is false positives. Antibiotics can give false positive results in galactomannan, which is not the same in beta-D-glucan. So patients on antibiotics, try and send beta-D-glucan for your follow-up. If you are suspecting aspergillosis, try and do galactomannan. Am I clear?
Bupropion.
Bupropion. Answer is bupropion. Try to have to search and find out the answer. What is the answer?
Steroids.
Steroids. Okay.
Yeah.
So underlying malignancy treatment is the first option you are supposed to write. If you are getting into medical oncology and if they ask an viva thing, so targeting the underlying malignancy is your first treatment for hypercalcemia. I mean, first answer for hypercalcemia. Obviously, you will be giving the first denosumab or zoledronic acid and start him on hydration and diuretics on that. Which is the high risk one? Not high risk one. Answer?
11, 14.
14.
11, 14, 6, 14 hyperdeployed. Okay.
11, 14.
This is easy calculations. As of now, only this much I could prepare. Baki in the next session. Okay.
Okay, sir.
Thank you so much.
So, write up all your controversial questions and keep. We will discuss in a later part. Okay.
So
Okay,
when
sir.
will the next session be held?
Whenever I am able to do all this again. Very shortly. Within this week, we'll try and finish all. Okay.
Okay, sir. Thank you, sir.
Okay, sir. Thank you, sir.